Hello, everyone, and welcome to Focus on Application for our Master Course in Trauma. I'm Dr. Megan Schmidt, and this week we will be looking at the module on Beyond Fight, Flight, and Freeze. This is a part of our program where we look at key insights from the week and how to apply those in our work with patients. And joining me today are Dr. Kelly Wilson. Hello, Kelly.
Good to be here.
And Dr. Usha Tumalanara. Thanks for being here, Usha.
Thank you, Megan.
So let's start with you, Usha. Can you talk about what stood out for you this week in this module?
Sure. There are a couple of things that stood out to me in particular. The first has to do with the attached cry response. And to me, this particular response and the way it's been described really reflects the deep emotional needs that our clients bring with them when they first meet us and what they do with those needs. And sometimes it takes the form of wanting to be saved and rescued, idealizing the therapist, and what then gets mirrored back from the therapist, in terms of what is our need, what is my personal need, and trying to really help and reverse, in a sense, the effects of a traumatic event or an experience, how to make things better. And so there's this pull that the therapist experiences in trying to not only be effective as a therapist, but sometimes even beyond that, to change what has happened in the trauma itself. And so this I find is a really important sort of foundation to the work itself in trying to negotiate the needs of the client and the needs of the therapist at any given point. And they can change over the course of treatment. They can change over the course of doing work with one client versus a different client. And there is a particular way in which that attached cry response feels depending on the combination of myself working with one client versus a different client. And another takeaway from me relates to how clients try to please us as the therapist, that how clients want to please in general in the context of their relationships. And often what I find is that this happens because a person is trying to mitigate traumatic stress. They're trying to figure out a way to make things less bad, to prevent something worse from happening, either in reality, sort of, physically, keeping something bad from happening, or intrapsychically, within oneself, trying to see how can I make this more tolerable for myself? How can I also possibly control a situation better than what I had in the past? So that kind of pleasing response, I think, is so important. It happens in a multiple different contexts in terms of clients' relationships. And there are social contextual issues that demand clients to please, which I also think is really important to understand. And Thema Bryant Davis makes an excellent point regarding this, or using the example of African Americans and Black people trying to, figure out and understand, predict perhaps what a white person might be thinking, and therefore change one's behavior in order to have an interaction that is more tolerable, more bearable, safer in a sense. So this to me is a critical thing to understand, both in the context of individual therapy, but also what happens in broader social dynamics that then gets internalized and reproduced in the therapy context.
Thank you, Usha. And Kelly, talk to us about what stood out for you this week.
One of the issues that really popped up in there and, came into focus for me was when I was looking at the section on cries for help versus cries for rescue. And I think there's a kind of a more general issue in there that cuts across what do we do with our pain in social contexts. And, the initiation of that cry for help in its most primitive form in a tiny little baby, the little baby isn't trying to get anyone to do anything. It's really just a pure expression of discomfort or, of some sort or another. It gets co-opted into rescue contingencies pretty readily, because it alerts the ones around you and generally brings them in. And, with the and by that I mean the wrong kind of social contingencies, that can rise to pretty high strength where a person insists that you rescue me, from my pain. So I don't just tell you that I'm in pain. I tell you that I'm in pain in such a way that it is your job, to alleviate that in some way. And that is really hard on relationships, and usually the devil of it is it works in the short term generally. People will be drawn in, but over the long term, very often you're faced with the sort of fact of human suffering, and you and I cannot alleviate, the fact of human suffering, and to have that constant insistence just causes people to begin to go away, and it feeds a narrative that the person has that is sort of like, my pain is too much to bear. Watch, here I put it out in front of other people. And, oh, sure, they rise to it at first, but eventually they get the full weight of it and they leave. There's a different thing that can happen, which is just expression, and that is explicitly not demanding, to just presence it. From my mother's side of the family, I think I cry easily. And I've probably never done a psychotherapy that, lasted more than a half a session that, where I wasn't brought to tears by the things that I hear from people. Clients, very often, it'll activate that sort of, oh, I knew I shouldn't have put that out there because I'm insoluble. And they'll try to relieve me, and the draw is there to relieve someone of that. And they'll try to rescue me. And I'm very explicit, like, I'm here on purpose. I'm honored to be here with you. And I could be somewhere else doing something else. I'm here. And so there's this, for me, an embodiment of, like, to carry my own pain willingly is, and to remain curious and to lean in those moments, is to encounter pain in a different way than a person who's kind of caught in those cycles of either restricting other people's access to their pain or sort of dumping it out there and, ultimately being unsatisfied with, it producing anything, but to just have it without demand is a practice that I think, we can cultivate in that, in the therapy session.
Thank you, Kelly. Let's stay with this topic of attach cry for help and how intense that trauma and survival response in a patient can feel. We heard Dr. Stephen Porges talk about how uncomfortable it can be for the therapist. And Usha, I'm wondering if you have ever experienced this discomfort. Perhaps you have a particular patient in mind, and how did you work through your discomfort to stay present with that client?
Yes, there have been many moments where that attached cry kind of response came up, and I had a reaction to it internally, and tried to think about what do I do with that, and how can I respond to that in a way that's meaningful and also authentic, with my client. And one example comes to mind where I was working with a client who had been sexually assaulted as a child, and she was also facing a lot of racism in her workplace when I had met with her, when I had started to work with her. So she was sort of dealing with experiences of racism. She's an African American client, and she had been struggling with traumatic stress for years. She had never talked with anybody about what happened to her as a child. And so this was the first time she had seen anyone for sort of a formal type of help. And one of the things that she said to me was, I am tired of being a strong Black woman. And that was in our very first session, that she just sort of sat back and just said this. And at the same time, she felt that she couldn't ask for help. And she explained in many different ways how she had relied on herself all her life, and that she really didn't look to get help. So it was really hard for her to be there. And yet she's telling me, I'm tired of being a strong Black woman. And so I'm immediately moved by this, as I listen to her, and she's carrying this weight of the sexual trauma, a lot of relational traumas in general, I would say, along with the racism that she's describing. And that being heightened, I have to say, in the last many years, over and over again, and, watching the racial violence escalate over the last many years as well, that's been the context in which we're working. And so internally, I have been feeling a lot of anxiety about this, and a lot of anxiety about our race relations in this country, racial injustice in our country, and really wanting to help in a meaningful way when I'm sitting with her. And she, even though it's not an explicit cry for help, it's not an explicit thing that she's telling me, it's clearly present in the room. And I find that this type of communication is not uncommon. It's not always direct, it's not always like, you have to help me and save me. But I'm going to tell you something that indicates how badly and how much I need you. I need someone. And so I had to really think about, what can I say to her? And what can I communicate to her that helps her know that I want to help, but I'm limited. I'm limited because of how much she is dealing with, the reality of what she's dealing with, but also my limitations and what I can do to fix everything as much as I want to. And one of the things I did say to her really related to exactly that, this feeling that I had in me that I felt, and I communicated very directly. And I said to her, I want so much for things to be different than what they are. And I'm going to do my best to figure out with you what might help. But I can't change everything, and I can't change all of these things. And so part of my work was to really kind of recognize what I could and couldn't do, but also what I wanted to do, what I wished to do, and trying to sit with all of that and how complicated that is to be communicating to my client that I both wanted to help, and I'm going to figure out some things that I can do to help, but I really can't help in every way that she wishes. And that's often a very painful thing, actually, for me as a therapist, to feel like I have less power to change things contextually than I do. But on the other hand, that I do have some power to do some things, so it's really a very complex kind of set of feelings that relate to this attach cry response.
Thank you, Usha. I'm going to shift us to talking about the submit collapse response. And Kelly, this question is for you. We heard Ruth Lanius talk about how easily practitioners can misidentify a collapse submit state that's related to trauma as what some people call treatment resistant depression, or we could say very entrenched and severe depression. I'm wondering how you look at the key symptoms and signs that differentiate those two from each other.
Well, whenever I see the word treatment resistant or any of the other code words that get used in mental health for treatment resistant, bells start going, off in my head. Those are words that are almost always used right before you use these other words, which are, I've got this referral for you, or, you might need, a course of ECT, or, those are the words those are the words that go with you're just about to be punted, they are in your file right before you become someone else's client. And, I'm again it. I'm not fond of diagnostic labels, even a little bit, because the complexity of the palette is, never captured by the, menu of symptoms. And, I come from the behavioral tradition, so, my assumption is the rat is always right. So whatever the person is doing in there, makes sense. And if it doesn't make sense to me, it doesn't mean that there's something especially wrong with them. It means that I've failed to understand the context in which they're responding adequately. Now, I may not be able to get there, but those are moments where, the top line response for a therapist when they see something that just looks so refractory and so immovable is to lean back and to try to figure out a way to lean back. That's my first response, but I have a kind of a backwards compass, which, is like, 100% reliably pointing in the opposite direction that I need to go. So everything in me says lean back. I lean in, and I think, what am I not seeing? What am I not hearing? And I'll ask people about that. If I notice myself wanting to give up in the sense of a diagnosis, then I might ask them, I wonder if you've reached out to people and it looked like they might be able to help you, but then they just gave up. Lean in. And I wonder what I'm not hearing and what I'm not seeing. And my expression is one of deepening curiosity. People are not used to having that happen. When their outward appearance is that utterly collapsed, it causes people to give up, which, if you're really in that hard of a place, it's almost a relief if people give up, because you can see the pain you're causing in them. And at least if they give up, you're not causing that much more pain. When they encounter in the face of that a deepening curiosity, and I would add a persistent curiosity, it destabilizes that repertoire. It destabilizes that kind of collapse because it's not having its usual functions, which are either rescue or abandonment. Rescue, people don't know what to do with it except rescue or abandonment. They've had those treatments. If those treatments were going to work, they would have already worked. So that my practicum team, when I was still at the university, there were like the clients that, like the general descriptor would be sort of, not appropriate for treatment in our clinic. That would be like, just send them to Kelly's team. I have a special affection for, really complicated people, and for teaching people to sit with really complicated people. You have to be willing to really not know hard, to sit in the face of that. And it seems like a right thing to do for me. Like, I don't know for anybody else, but for me, it seems like the right thing to do.
Thank you, Kelly. Your answer made me think of another survival response defense in this module that gets misdiagnosed and misunderstood, and that's attach cry, which is hard to sit with, hard to be with, and is often misunderstood as borderline personality disorder, another label that therapists react to and may not want to lean in and work with. So such a critical point that we have to work through our reactions to clients and ask ourselves what is functional and helpful about what they're doing, and not get caught up in judgment about the seemingly non-functional parts. There's a function and a purpose to attach cry. There's a function and a purpose to collapse submit. And I appreciate that point. We have to work through our own reaction and get curious. We're really going to miss something important. Usha, I'd like to switch to you and follow up on a point that Dr. Thema Bryant Davis made about how we as therapists language in sessions with clients can cause them to censor their selves and start telling us what they think we might want to hear, what we think is acceptable. I'm wondering if you've ever run across this in your practice, and tell us a little bit about how did you know it might be happening and what did you do to respond to this dynamic with a client?
Yeah, sometimes this has happened sort of midway through a treatment, a therapy, where we might be doing, the client and myself might be doing what we think is really excellent work, in terms of the client trying new things in their life, feeling more stable in terms of kind of the symptoms of traumatic stress, but really still working on relationships, for example. So I'm thinking of a client who, felt that she was ready to try developing some new friendships, and friendships in which she was hoping to have a better sense of mutuality, better sense of mutual caring, which she had not experienced in most of her relationships in the past. And so she was getting to know a new group of people, and we talked a great deal. We had by that point processed a great deal about sort of what some of her fears are and what she kind of carries with her into meeting new people. And she had made some progress into, figuring out how to be with this new group. And in one session, she came in saying, I just really messed up. And I have to tell you about it. And she proceeded to tell me how she was asked to do something with this group, and she just told them no because she was just afraid of getting to know them more and worried about really them not liking her. And so she managed that by just letting them know that she wouldn't join them for an outing. And she came in thinking that I would be very disappointed by that. And so in that instance, she shared it very directly with me, and we processed, why she was so worried that I might be disappointed. And we talked about her fears of me not liking her, leaving her in some way, psychologically leaving her, being more absent. And in that instance, we could talk about it. But with the same client that we were able to talk more openly about this, I found that she would sort of censor a little bit more when it came to a romantic relationship she was involved with, and she would say things to me like, yeah, I'm really opening up to him, and I'm really, starting to see that things are going well with him, and we're getting closer and deeper, and she would describe these things to me, and it made me wonder, in the context of what she had previously talked about with this group of friends, if that was actually really happening and in this romantic relationship. So I'm providing the context for the censorship piece that happened in our work together. And one of the things I brought up with her at one point was, it seems like you are enjoying being with him, but I can't help but wonder if you're telling me everything that you'd like to really share with me. And she immediately said to me, well, I don't want to let you down, and it came sort of on the heels of our previous conversation around this group of friends. And so this theme of worrying that I would be disappointed or I would not approve kept coming up for her. And I had to kind of think about, well, what is it that I may be doing to contribute to her feeling that way, in addition to what the traumatic stress might have done in shaping her own feelings and responses to me. So I did ask her at one point, what, do you think something is happening between us, or something that I may be doing that, kind of leads you to feeling that way? That you can't really share certain things with me. And one of the things that she talked about is really the transference that she, had towards me, which she thought, well, you seem like a kind of person that wouldn't make those kinds of mistakes, that you wouldn't have those kinds of problems that I have. And that led into a deeper conversation about the differences that she perceived between me and her, and that she actually needed to see me as more vulnerable. In order for her to really share and censor less. And so it's hard to talk about censorship, in my view, without having a full sort of, context of in which that censorship is happening, not only because of the traumatic stress, that's certainly, a significant factor, but also what's happening in the therapeutic relationship and what's happening between us and how I might be contributing to that potentially. And what she might be doing with that. So that's an example of how I'm taking what Thema Bryant Davis has spoken about.
Thank you, Usha. Thank you for your specific languaging and how you would begin this conversation with a client to uncover, is that really what's going on? So, Kelly, I'd like to go back to you and ask about something that Deb Dana brought up about the submit collapse response. And that is that it can be very dysregulating for therapists to sit with someone in a collapse submit state. In fact, we were talking about it just a little bit ago. And have you ever had this experience sitting with a particular patient? You might have someone in mind. And how did you work through that? What did you do with your own internal response to them so that you could be present and effective?
Well, as I suggested, I have a particular affection for the clients that other people most want to refer, and I don't know how I would. It's interesting to me, I suppose it's because I've been such a difficult case myself. It only seems right that I would offer back into the world what helped bring me into the world. I'm thinking of an individual I saw some years back who had some of those labels applied to them that are sort of code for, maybe you'd be a really good client for someone else. Including a borderline personality disorder diagnosis. And they would at times it was almost like they had like Seattle pulled down over their head or something. There's this kind of shroud, this impenetrability. And they were impenetrable not just to other people, but to them, but to themselves also. And I think that, as I think about this particular client, she shared this dual kind of quality that we sometimes see in really complicated folks, of a really acute awareness and non-awareness, interpersonal awareness at the same time. In some regards, there was this kind of shrouding and interpersonal kind of disconnect. But on the other hand, there was a sensitivity she had to the people who she was inhabiting this world with. And I think there's one thing of what we tell our clients, and, it's probably a nice thing if what we tell them converges with how we respond to them otherwise. But I think that how we, the regard with which we hold them, teaches them about their own response to themselves. And so if we see this collapse and, we dash in as if rescue is imperative, we are telling them, you are someone who needs to be rescued, who must be rescued from yourself. If we refer them, we tell them, you are someone who, when the full weight of you is known, will be left. And it is a kind of guidebook for them to how to regard their own, the weight that they feel. This particular client, I remember being in a session with her, and I couldn't get eye contact. Her gaze is downcast and her whole demeanor is sort of, closed in this way. And I spent a lot of time in my early training working in intellectual disabilities in group homes, people who had profound and severe disabilities, who had been deinstitutionalized from, all the way into their, middle adult, middle age, had been in institutional settings. And so their social repertoires were really just pretty absent. And there'd be, I'm here, look here. And it's that old repertoire sort of rises up in me, and I'll find myself doing it in therapy sometimes with, neurotypical adults, as here, And I asked her to look at me and to look up to me. And I said, I wish that you could see what I see when I look at you. Just period. I wish that you could see what I see when I look at you. Now, could she see what I saw? And what I saw was, what you see often with folks like that is you see these great, valleys, this kind of states of utter collapse. But these are often people who are brilliant and funny and sensitive and, in ways that you would never predict, if your attention was drawn so much to that low spot. And I have a deep longing to see that. I know that it's there. And when they look up at me, if I can get, just a peek, they can see that they're looking into the eyes of somebody who sees something. They don't know what. It's puzzling to them. But that change in regard, I think, speaks volumes to the regard that they might have for themselves. And so, is it frightening? It is when I'm most concerned about managing how I feel in the session. But, as soon as the concern becomes, how can I be useful to this person? It takes that, focus off of, there's something going on in that room that's more important than me managing how I feel. My clients bring me back every time.
Thank you, Kelly. It reminds me of another point that Deb Dana was making about when a client is in submit collapse, it can feel so hard to be or stay in relationship to them. And you using that phrasing, I wish you could see what I see when I look at you, is this way that you tried to stay in that body-to-body, person-to-person communication with them, even when they were going down. And
there's a little piece of perspective taking in there that I use a lot of in my work. And it's a funny kind of perspective taking because she doesn't really know what I'm seeing. It's actually puzzling to her that anybody would say something like that. But
it brings her out of herself a little towards you, and
she has to try to imagine what is it?
It's a little bit of connection.
Yes.
Yeah. Thank you for that example. So I want to thank both of you for commenting on further practice insights in this model where we took on survival responses beyond fight, flight, and freeze. And thank you very much for your time today.